Bismillah ar-Rahman ar-Rahim. Hello everybody, I am Dr. Muhammad Misbah Taha, lecturer of cardiology at Zagazig University. Our topic today is about the pericardial disease, one of them of course, which is called the constrictive pericarditis. Okay, regarding the introduction, first of all, there is too many forms of the pericarditis, the inflammation of the pericardial tissue. Acute form, subacute form, and a chronic form, which may be or not be symptomatic. It may go asymptomatic at all, or comes with some symptoms that later may deposit fibrin, which is in turn can evoke a pericardial effusion, which is some fluid form through the pericardial space. Later on, that leads to a pericardial inflammation and chronic fibrotic scarring after that. Later on, calcification, which finally leads to a restricted cardiac filling, hemodynamics, and of course this is some sort of the pathophysiology of our constrictive pericarditis topic. Okay, if we want to define this constrictive pericarditis, I can say it is a state of thickened fibrotic pericardium of whatever the cause, as I will later on mention the causes, that leads to impedance of the normal diastolic filling process. This usually involves the parietal pericardium, but sometimes it may involve the visceral pericardium too. The causes of this constrictive pericarditis are of course similar to the causes of the acute pericarditis too, as idiopathic, after radiotherapy, after a cardiac surgery, some of the connective tissue disorders, which are most of them are autoimmune diseases, and of course a bacterial infection like the tuberculosis. If we want to classify the constrictive pericarditis, we could say a transient constrictive pericarditis, a chronic constrictive pericarditis, and effusoconstrictive pericarditis. Regarding the first type, which is a transient constrictive pericarditis, it's a subtype of constrictive pericarditis. The underlying pathophysiology usually relates to the impaired pericardial distensibility rather than the fibrosis and the calcification process. It usually follows the aspiration of the pericardial fluid, which is called post-pericardiocentesis of pericardial effusion. Second type, which is the chronic form of constrictive pericarditis, which is long-term, and this yields the worst prognosis of the three types. Effusoconstrictive pericarditis, it's a clinical hemodynamic syndrome in which there is both constriction of the heart by the visceral pericardium in the presence of an effusion in the free pericardial space too. If you want to understand the pathophysiology more than that, I could say that in constrictive pericarditis, the heart is encased by a non-compliant pericardium, so the normal inspiratory decrease in the intrathoracic pressure is not really transmitted to the intracardiac pressure too. This effect amplifies the inspiratory decreases in the pulmonary venous pressure, as these veins are primarily extrapericardial, so they are not affected, translating that to a reduced left-sided inspiratory preload and of course a reduced left-sided inspiratory stroke volume. We have two domains that have a pathophysiological similarity, one called a restriction and another one called the constriction. In the both domains, there is abnormal increase in the ventricular pressures that impedes the filling of the left ventricle. Our topic today is the constriction type, which is a pericardial disease in itself, and it's called a constrictive pericarditis. The other type, which has a restriction, it's a myocardial disease, heart muscle disease, which is called a restrictive cardiomyopathy. Both types have a very pathophysiological similarity, and you should differentiate between both of them to reach to the right diagnosis and the right treatment as well. The diagnosis of constrictive pericarditis is not easy. You could do that using the exclusion strategy, and of course you have to have a high clinical suspicion to get it. Firstly, a history of a cardiac surgery, a radiation, a TB infection should heighten the clinical suspicion, especially in the presence of the other symptoms that I will say later. This condition is difficult to diagnose. It may be confused with other cardiac conditions, as I mentioned before, the restrictive cardiomyopathy, which occurs when the heart chambers cannot fill with the blood easily because of the stiffness in the heart muscle itself, not in the pericardium. And the other pathology called a cardiac tamponade, which is the severest form of the pericardial effusion. There is too much fluid between the pericardium and the heart muscle, and that compress the heart, which impedes the filling process too. The symptoms of the constrictive pericarditis could be as the symptoms of the acute pericarditis too, which is a difficult in breathing, a fatigue, weakness, low-grade fever, and chest pain, which is not ischemic in its origin, and you could know that later with more specific details about the character of this chest pain, and you could refer to the history taking chapter for that. Regarding the signs, it could go through a congestive heart failure state with lower limb pitting edema, bilateral and ascites form. Through the jugular veins of the patient, neck veins, you could see a sign called Friedreich sign, which is an exaggerated drop in the diastolic central venous pressure, particularly with a stiff calcified pericardium, and it's a sign of abrupt collapse of the neck veins and a marked descent in the central venous pressure waveform as a prominent rapid X and Y descent. And a cosmal sign. This cosmal sign, normally the jugular venous pressure decreases during the inspiration because of the inspiratory fall in the intrathoracic pressure. It's called a suction effect. But in this constrictive pericarditis and this intrathoracic pressure are not transmitted, as we said in the pathophysiology, so there is a paradoxical increase in the jugular venous pressure during the inspiration, which is called the cosmal sign, and it's a true physiologic paradox. And the heart, you could auscultate. Through the auscultation you could hear a high-pitched early diastolic sound that occurs due to the unyielding of the pericardium, sudden arrest of the ventricular filling, as of course due to the constriction, which is called pericardial knock. And of the lungs, you could see some sort and the pleural effusion, which associated with our effusion in the pericardium too. The investigations could also help. Beside the laboratory profile, which can go through the same process as the pericarditis causes, the ECG, you could see atrial arrhythmias may be present. The amplitude of the QRS complex and the T wave may be diminished because of some sort of effusion too. The QRS complex may be abnormal in addition to a low voltage. The mean QRS vector is usually normal. So the ECG is really non-specific to this pathology. A chest X-ray could also help. A normal or mild enlargement of the cardiac shadow. You could see the calcification of the pericardium detected in up to 50% of the cases, but it is not specific, which I mean a calcified pericardium is not necessarily a constricted one. Lateral chest X-ray should show too a thickened AV groove, and the anterior and diaphragmatic surface of the right ventricle are thickened too. You could also see some level of the pleural effusion, as we said in the auscultation. It's also occur in about 60% of the cases. Of course, the echocardiography is the most important one. You could detect pericardial thickening, calcification, and effusion, and you could know the level of effusion, mild, moderate, or severe. The ventricular septal motion abnormality, which is a feature of the exaggerated ventricular interdependence. The inferior vena cava is universally plethoric, distended, which is a marker of the increased venous pressure. And the most important one is that dynamic respiratory changes in the ventricular filling pressures are exaggerated due to the inspiratory decrease of the mitral valve inflow pattern and increase in the tricuspid valve inflow pattern. This, of course, because of the exaggerated respiratory preload changes. Finally, you could confirm the diagnosis using the CT or MRI modality, which can detect the thickening of the pericardium and confirm the diagnosis. Of course, it's important to differential diagnose the pathology of constrictive pericarditis with other form, as we mentioned before, as the restrictive cardiomyopathy, which is a disease of the heart muscle itself, and of course the pericardial tamponade, the severest form of effusion, and also the early state of the pericarditis. The prognosis of the constrictive pericarditis is not really good. It's a potential curable disease if diagnosed early, which is difficult, but it's potentially fatal if it is left untreated. Undiagnosed patient can have a 90% mortality, which is very high rate. Regarding the treatment, which the medical treatment is not helping so much. The subacute forms of constrictive pericarditis may respond to the steroids if treated before the pericardial fibrosis develops. Okay, regarding the diuretics, especially the loop diuretics, are the mainstay to relieve the congestion and to optimize the clinical volume status, but you should be very cautious as it may lead to decreasing of the preload to the point of reducing the cardiac output, and that requires a very close monitoring. In general, and especially in the transient forms of constrictive pericarditis, a heart rate regulating drugs as beta blockers and calcium channel blockers should be avoided because of that. The sinus tachycardia that commonly occur in the same situation of the constriction has a compensatory function, maintaining the cardiac output in the setting of the fixed stroke volume. The most important are the medications used to treat the underlying etiology of the pericardial disease itself, as anti-TB therapy if the cause was a bacterial infection of the tuberculosis, and the treatment of the complication is also too helpful. If we have atrial arrhythmias, you should direct the treatment to this arrhythmia itself. The surgery, does it have a role in this pathology? Some patients with advanced cardiac symptoms related to the constriction may derive a little benefit from surgery, as these are often the high surgical group risk, and the surgery here called a complete pericardiectomy, which is a very high risk surgery, but it could have some benefit. Thank you so much.